Hi, good evening, everybody. A warm welcome to the ICU webinar series. I'm Dr. Avya Bansal, and I take immense pleasure inviting all of you today. At the onset, I'd like to thank the Indian Chess Society and Dr. Amita Nene Madam, Dr. Rajadhar Sir, and Dr. Sandeep Salvi Sir for taking an initiative and organizing this wonderful webinar series in Intensive Care Unit. I would also like to thank CIPLA, being our academic partners, and especially to Mr. Vipul Ranjan for being so fantastic and meticulously organizing this entire thing. Now, like we all know that fungal infections are something which we see very commonly in our ICU and often keeps us puzzled as to what next needs to be done, whether to treat, not to treat, depending on the parameters, clinical deterioration or improvement, and sometimes when to escalate or de-escalate. It's a challenging question which we see and often leave the decision to our intensivists. But we as pulmonologists need to bear the brunt as lung involvement is often missed and diagnosed at a later date. So we'll be talking about fungal infections, and we have our warm faculty with Dr. Chawla speaking on fungal infections in the ICU. But before we begin today's session, I would take immense pleasure as being a part of the core committee for NAPCON 2025 in inviting all of you to jump and join us wholeheartedly and support our NAPCON 2025 in Pune from 23rd to 26th January. So please, warm welcome to all of you and ensure that this event is a huge success. Coming to today's webinar, we have none other than Dr. Rajesh Chawla sir, who needs no introduction. Dr. Chawla sir has been an esteemed faculty for more than 25 years. He has been the past president of the National College of Chest Physicians, the past chancellor for the Indian College of Critical Care Medicine, the past president for the Indian Society of Critical Care Medicine, and is a senior consultant respiratory and critical care physician at the Indraprastha Apollo Hospitals in New Delhi. Sir has authored several chapters and books, including on ICU and ventilatory management, and has given talks at numerous forums, with me being a student and listening to him speak on several of these occasions. Critical care being a topic which is very close to his heart, I see no person better than him to guide us and talk to us today on the importance of fungal infections in the ICU. Handing over the session to Dr. Rajesh Chawla, sir.
Good evening. Thank you very much, Avya, for very nice introduction. And thank you very much, the audience, for joining on at this time, which is a dinner time at 8:30 p.m. and listening to fungal infections. See, when you are managing the critically ill patients, when I started practice in 1985, that time we were not talking much about it, and it was never beyond fluconazole, which we used to use, or the conventional amphotericin B. And now with the improvement, or rather I would say with the increase in population of immunocompromised host with chemotherapy, transplants, and other things, the fungal infections, and treating patients with multiple antibiotics, the fungal infections have become really very common. So I'm going to talk in next 30 minutes the common problems and challenges which we encounter in managing these infections in the ICU. If you see among the fungal infections, of course, the Candida is the number one, candidiasis. 70 to 90% of the infections still are candidiasis. 10 to 20% aspergillosis. Very few cases of mucor. We saw a lot of cases during COVID, but now mostly restricted to the transplant patients or people on a chronic steroids or diabetics. And then the other fungal, which we are not going to talk today, is the Pneumocystis cerevisiae. That's also a fungus which we see in the immunocompromised host in the ICU. If you see, the majority of patients of candidemia in the ICU are restricted to the medical wards, intensive care units, and the surgical wards. And Candida is the fourth most common cause of causing the bloodstream infection after the Staph aureus and the others. If I see the species of Candida, when we were young, Candida albicans used to be the very common organism. Now the non-albicans have dominated, and glabrata, tropicalis, paracillosis, cruzi, and albicans. These are the 5 most common pathogens we encounter in the ICU. And 50% of the candidemia occurs in the ICU settings because of this. If you see in Indian settings, it is the Candida tropicalis, which is the most common as compared to the USA, where still the albicans is one of the common organisms. If you see the prevalence of the uh, fungal infections, incidence of ICU acquired bloodstream candida infections. Australia has about 2.1 per thousand, India has 6, and France has about 6.7 per thousand admissions. So, very, very common, and it is increasing. And if you see the why it is important to know the species, because mortality with albicans is less as compared to glabrata or cruzi, which have the higher mortality. And the simple reason is they are resistant to the commonly used azoles. There was a study done by Dr. Aruna Loke, who's done a lot of work on fungal infection in India. He was initially from PGI Chandigarh. They did a study on 27 centers, and this data of 6.51 candidemia cases per thousand ICU admission actually came from there. And these candidemia, the moment you say the person has candidemia, the chances of mortality are almost 30 to 40%. And they found that azole resistance and a multi-drug resistance in Indian candida species were 11.8% of the isolates. We get the fungal infection early. If you see the US, they start thinking of fungal infection after the 3rd weeks. But in our country, the mean they have seen the data is 10.8 days. So even earlier, when a patient is admitted to the ICU, about that many days, we start thinking of fungal infection, and that is how they are common. And even earlier also, we see in immunocompromised patients. Now, the other very important thing which has occurred in last about 10 years is the emergence of a drug-resistant candida, which is called the Candida auris. It's a super bug. It is resistant to most of the common antifungal we use. And the moment you say the Candida auris, 50% mortality, even the best of center. And it is a purely a nosocomial infection. Candida auris only occurs in the ICU. And if you have one patient, you must separate it. Otherwise, many patients in your ICU are going to develop this. As you can see, 93% resistant to fluconazole. Even echinocandins are resistant to the Candida auris. Although still, because the 7% resistant, we still choose as a drug of choice for Candida auris. But it has a very high resistance to even the amphotericin B. And this is the percentage of isolates after the Candida tropicalis. Now it is the Candida auris rather than the albicans or the paracillosis. Why does this occur? Because of the nature of infection in the ICU. We use a lot of antibiotics. People keep on adding one after the other. They give it for a very long time. Do not restrict to the duration, which is patient who had undergone abdominal surgery like anastomosis and has peritonitis, multiple antibiotics. This is a parenteral nutrition, immunosuppression, steroids, IV central line catheters, candida colonization, acute renal failure, patient on dialysis, transplant, pancreatitis. All these are risk factors. And many of these patients will have multiple risk factors. And then that's how they become prone to the invasive candidiasis and candidemia. And you have to start treatment very early. If you delay the treatment, the mortality is very high, as you can see in this slide. Similarly, intra-abdominal candidiasis is the second most common form of candida in the ICU, and you can get in most of the GI organs. And the risk factors, as I was saying, anastomotic leak, multiple instrumentation, parenteral nutrition, all these are risk factors. Primary peritonitis is the one which has the highest mortality. And of course, the albicans and glabrata are the common in the abdominal infection. Now, pulmonary candidiasis. Somehow it is extremely difficult whether a person has a candida pneumonia or not. It is the most common colonized. People will isolate in the sputum, in the bowel, and they will start antifungal, which is really in an immunocompetent patient who doesn't have symptoms or has symptoms which are explainable by another illness, another infection. There is no need to start the antifungal, but these people everywhere people start treating the sputum or a ball when they isolate without any reason with the antifungal treatment. And uh, most often it is the and uh, you should only use if patient has no source of infection, if you definitely feel the person has candida pneumonia. Actually, to prove a candida pneumonia, it is debated, because if you are to really prove it, it should be in the histopathology. You should be able to show the fungus as well as the inflammation, then only you say it. But it is different in a patient who is immunocompromised. In an immunocompetent patient, you should only treat candida pneumonia if you're really sure that it is there. Then the renal disease patients, CKD and dialysis, these also are very prone to infection. The acute renal failure 5.7%, and a patient on CRRT can have a candidemia of 8 to 15%. Similarly, patient with the catheter can also have the fungal infections, but they colonize and the patient can have symptoms. They can even become hemodynamically unstable. So how to diagnose that person has a fungal infection? So there is a lack of distinct clinical presentation. There's nothing different from the pneumonia or the infection, bacterial infection in that particular area. So there are very non-specific fever, leukocytosis, skin lesions, it is the condition of the patient. It is the presence of risk factor. And when you have no other source and these symptoms are present, you start thinking of fungal infection. So what are the tests which are available? Direct microscopy, it's rapid, cheap, but cannot differentiate whether it's a colonizer but it can tell you that there is fungus. Culture, blood culture must be sent in a patient where you are suspecting, and you should send at least 20-30 ml of blood. Sending 5-10 ml of blood is not going to grow the fungus. Sensitivity is comparable to PCR. Then the histopathology, wherever possible, whether it is a skin or wherever possible, if you obtain a tissue and you find there, then you definitely sure. Then menin antibody in the blood, which is specific for the candida albicans. Then beta D glucan, 1,3 beta D glucan, it is available in India. It's a blood you have to send, and broad spectrum. It can really, if there is invasion, it can really tell you the person is having a fungal infection or not. It is false negative in patients who have mucor cryptococcosis, but it's a broad spectrum. If a person has a fungal infection, and if you find more than 80, if you are doing with the fungitel, then it is the possibility of fungal infection in that individual. PCR is another test. And as I was saying, if a person has beta D glucan, which is more than 80, and procalcitonin less than 0.2, you can say probably this person has a fungal infection, and their sensitivity is 96% and specificity of 98%. It is important to identify species. There are various methods available. Malditoff is available in India at many places. Within few minutes, it can give you non-commercial, is the most common. Most of the Indian laboratories are performing, and the others are available in some of the centers. And it is important to identify, because choosing an antifungal will depend on what kind of the species you are dealing with. When there is a candidemia, please do get examined the fungus, because if there's a candida ophthalmitis, although not very common, the outcome of the eye is very poor, and you have to give a specific drug which may not be kinocandin. Similarly, if there is a patient that has a candidemia, you should do an echocardiogram and look for if there is a involvement of the heart. A lot of scores have come, like colonization index and candida scores, and the other scores also. The useful of these is affected by low prevalence of invasive candidiasis, and specificity is only 50 to 80%. Positive predicted value is 1 to 30%. So wherever I'm thinking there are risk factors, I have patient has symptoms, I have no other source, then I would think of treating that person with fungal rather than relying on these colonization index. They're more for research purposes. How to treat them and whom to treat? There are a lot of drugs available. Azole have been available for many years. Now there is a resistance to azole, fluconazole, voriconazole, posaconazole, and now we have isavuconazole. Polines, amphotericins, echinocandins. We had three echinocandins for many years, and now we have a new echinocandin, which is once weekly rezafungin. And one has to choose appropriately in a particular patient. They have mechanism of action. They act on different, like polines on cell membrane, echinocandin on cell wall, and azole on the cytoplasm. So these are the three echinocandins which are the most commonly used, and they are used because they are minimum drug to drug interaction. You don't have to change during renal failure. They are safe even in hepatic, except for capsofungin, where you have to change the dose, and they're a broad spectrum of activity against most of the Candida species. The doses are very well known to you. The capsofungin 70 followed by 50, micafungin is 100 or daily, and anidulafungin 200 milligram as a bolus dose, and then 100 milligram once daily as a maintenance dose. Rezafungin is 400 milligram is given as a initial dose, and then 200 milligram once weekly. That is the advantage of rezafungin. It is a modification of anidulafungin, the rezafungin, which is available international market at some places, probably would be available in India soon. Then the polines are the other one, which we have been using. And now, if a patient is in a hospital for more than 7 days, he's got antibiotics in last 7 days, has got a central venous catheter for 7 days, and he has two of the following, and has a maybe positive beta D glucon, very low procalcitonin, you have no other source of infection, you should empirically start antifungal therapy in your patients. This is the most common way we start nowadays the antifungal treatment, because if you delay, if you wait for the definitive treatment, as you can see on this slide, that if you delay and you wait for the definitive test, culture, histopathology, the mortality would be higher. So that's why most of the time you end up starting the empirical treatment, and one needs to have a knowledge about these drugs and the where to start empirically treatment, and then you can modify based on the test whether it is there or it is not there. The guidelines have been last published in 2016. After that, they have not been published. And in non-neutropenic patient, the drug of choice are echinocandins. And for selected patients who are not fluconazole resistant, one can choose the azoles, and you can also choose azole as a de-escalating after patient is better and after 5 to 7 days. And you can de-escalate to fluconazole, but if it is a glabrata, then probably voriconazole would be the drug. And then, of course, you depend on the sensitivity report as well. And if it is a neutropenic, again, echinocandins are the choice, but then you can also choose the amphotericin B in these, and fluconazole at a loading dose of 800 milligram. Whenever you give fluconazole, loading dose is 800 and 400 milligram doli. Don't give a very small dose, 200 BD. A lot of people give underdosing of fluconazole. That's the proper dose whenever you want to use the fluconazole. Now, if you see all these three which are available right now, there's not much difference in the efficacy, but anidulafungin has a little better pharmacokinetic profile. Is you don't have to change in hepatic as well as the renal failure, and interactions are also more with capsofungin and micafungin. Then going on to the aspergillosis, this is another, because now we have neutropenic patients, we have patient on steroid, we have patient of bone marrow transplant, we have patient of solid lung transplant, patient on chemotherapy, and the other risk factor, as you can see on this slide, the hemodialysis, low dose steroids, COPD is another risk factor, diabetes. So all these you will find a patient having the aspergillus. We get, as a chest physician, a lot of calls with a chest x-ray showing nodules, cavities in a patient who is immunocompromised, has received immunotherapy, or he's on chemotherapy. This is one of the common presentation we see as aspergillosis, invasive aspergillosis in OPD as well as in the ICU patients. If you see these signs, you're very lucky. If you do a CT, you see a hello sign, and you patient has a maxillary involvement, and you are able to see the septate hyphae of aspergillus, it becomes easier. But again, remember, aspergillus hyphen sputum may represent colonization. Again, you have to see whether patient has a risk factor, whether patient has a possibility, whether there is evidence of invasion. And lung biopsy, wherever possible, if you can get a true cut biopsy or a bronchoscopic biopsy, which is not possible most of the times, the CT guided biopsy or the biopsy from the nose, wherever you can get angioinvasion, aspergillus can really confirm that the person is suffering from this. So if you are a positive histopathology and positive culture, there is no doubt. Otherwise, it's a possible or probable diagnosis of. Always remember, aspergillus also colonizes. If you just isolate aspergillus in a patient COPD without any sign and symptom or radiology, that doesn't mean anything. And there are a lot of criteria have been given by different based on that if aspergillus is positive in respiratory cultures, patient has sign, or there is a worsening respiratory efficiency, there is abnormal imaging by chest x-ray or CT scan, or along with it patient is neutropenic or is on glucose treatment or is immunodeficient. If criteria from all these four categories is present, you could diagnose aspergillus. But you should be very careful. Then one test which we use very commonly is a galactomannan test. It's the ball galactomannan is much more sensitive and specific as compared to the blood. Wherever you do, you must send the bronchoalveolar lavage for galactomannan test. You must remember that a lot of antibiotics make it false positive, and the dialysis patient can also have a false positive, but it is the level, the scenario, the risk factors which will make a diagnosis. The voriconazole is the first drug of choice, then intravenous in a seriously ill patient, amphotericin B is an alternative. Echinocandin may be considered if there is an in vitro sensitivity and patient who are not responder. There are studies to show combining the amphotericin B with the voriconazole, even combining voriconazole with posaconazole in the management. The third, which we see sometimes, I see quite common in a transplant patient. Every month, I see one or two patients of mucor because we do a very large number of transplant in a hospital. So we do see these patients. But otherwise, in immunocompetent patients, very rarely we come across mucormycosis now after the COVID. The construction is a major source of mold in the air in the hospitals, renovations occurring in the hospital. So you could see a rhinocerebral pulmonary mycosis. If I see a cavity in a transplant patient like this, I'm never wrong. It is mucor. So it is there, but it is not very common. So you should make a diagnosis. And if we are all pulmonologists, mostly you're watching, you should start the antifungal, which is amphotericin B. Usually we are giving combination amphotericin B and with posaconazole, and as early as possible after giving the few doses, and whenever possible, if patient is fit enough to get a surgical debridement. Then these patients, if it is a nose, then get a FES. If it is a lung, then you get a lobectomy or whatever is required. Then the prognosis in this patient is very good. So just to summarize, Candida infection is a multidisciplinary concern and threat to the healthcare physician. In ICU, restrict antifungal prophylaxis because azole resistance is already very high. Start prompt early antifungal treatment based on the risk factor and diagnostic-driven approach, and improve the fungal diagnostic in your knowledge as well as in your hospital. Select antifungal agent based on the local epidemiology, preferably with PK/PD advantage drug should be chosen. Achieve adequate source control wherever it is required. Use an adequate dose. Low dose is associated with resistance. Start early. Stop early inappropriate therapy. If you find there is another source of infection and you started antifungal, please stop. De-escalate whenever possible to oral. check duration of therapy. Mostly, if it is a candidemia, 14 days after the blood culture is negative. For if there is infection in the endocarditis, 6 weeks. Similarly, for the eye, also you give a 6 weeks. But then you should know how long to give. But mostly, it is minimum requirement is about 2 weeks. Have good infection control so that you don't have spread of Candida auris. Always look for Candida auris. The mortality is very high if it is Candida auris. And antifungal resistance is rising, and separate emphasis should be laid on the antifungal stewardship. Anti-Anidula fungens has a little better pharmacological profile among the echinocandins, and new echinocandin which is coming up is a rezafungin, which is once a week. Thank you very much.
Thank you, Dr. Rajesh Chawla, sir. I think that was a fantastic presentation, and you have comprehensively covered all major aspects of fungal infections, right from the diagnosis to the therapeutic options available to the treatment challenges which we often find while managing these patients. So, thank you once again, sir. Now, I would like to introduce our esteemed panelists for today's session. I would be starting with Dr. Radha Munje, madam. She again needs no introduction. Madam is the professor and head of respiratory medicine at the IGCMC Nagpur and additional dean at the same college. Madam has received multiple orations right from Dr. S.N. Tripathi oration at NatCon 2015 to the Mukaddam oration, the S.P. Agarwal oration. Madam has been Professional Excellence Award by the Government of India on the World Tuberculosis Day in 2021. She has been the organizing chairperson for NatCon, the governing council member of the Indian Chess Society from 2019 to 23, has a rich experience of over 33 years of teaching respiratory medicine, and has trained generations of respiratory medicine students, and has been a mentor and teacher to almost more than 200 postgrads till date. A warm welcome to you, madam. Next, I would take the honor to invite Dr. Preeti Sharma. Dr. Preeti Sharma is a senior consultant pulmonologist, critical care and sleep disorder specialist at the Healing Super Speciality Hospital in Chandigarh. She has an evening OPD at the Breathe Easy Clinic at Mohali, has been the gold medalist and won poster presentation awards at various conferences, and has presented as a speaker at national and international conferences. She has been a panelist and chairperson at various CMEs, is an IDCCN teacher and the examiner of the IDCCN. Her area of interest are airway disorders, interstitial lung disease, and critical care medicine, and is a member of various eminent societies. A warm welcome to you, madam, as well. Next, we have is Dr. Komal Shah. Dr. Komal Shah is a gold medalist in DNB respiratory medicine from Jaslok from Bombay. She has a fellowship at infectious diseases from CMC Vellore in 2022 and John Hopkins Intensive Infectious Disease Fellowship in June 2024. She is currently working as an associate professor in the Department of Respiratory Medicine in the Vasantrao Pawar Medical College, Nasik, and is a consultant infectious disease specialist at the Ashoka Merikawa Hospital. She's been a national faculty for various national and international conferences, has achieved the Best Paper Award 2021 and 2023 at NAPCON and at the Mahakritikon in 2023, has received the MUHS Research Award in March 2024 and the prestigious ERS ICS Travel Grant to Vienna in Austria 2024. Warm welcome to you, Dr. Shah. And last but not the least, we have Dr. Antonu Kalliath. He is a consultant intensivist and pulmonologist at the Amla Institute of Medical Sciences, is an ACLS and BLS instructor and provider, has 7 national and international publications in patient communication ethics, won the Free Paper Award at the Pulmocon 2024, has been a faculty at various national state conferences, is a provider for early management trauma course recognized by the TCMC, is a member of various national bodies, and has received the CMC Vellore Certified Course of COVID Management IDCCM in 2020. A warm welcome to Dr. Antony as well. We will now be starting with the questions.
Can you hear me? Before you go ahead, did we forget to introduce Preeti?
No, ma'am. We introduced Preeti, madam.
Introduced. Sorry.
Yes.
But I have a pleasant task of introducing our moderator, who is carrying forward this wonderful webinar on fungal infections in ICU, and he is none other than Dr. Avya Bansal. He is a consultant pulmonologist at Bombay Hospital and Research Center, and he's also an honorary pulmonologist for even Mumbai Police Hospital. He has already earned, he started earning his accolades right from MBBS. So he has had his Ratan Tata scholarship during MBBS. He has been a university topper. He too has received ICS ERS travel grant in 2019. He has been trained for ILD by ERS in Germany. He has his publications which are national and international, and he has also set up an adult vaccination OPD in Bombay Hospital and has also received ET Times Inspiring Respiratory Specialist Award this year, 2024. So, Avya, we are so glad to have you here and moderating this session. And before I hand it over to you to take forward, I invite everybody who has logged in for Pune NAPCON, which is going to be there from 23rd to 26th of January at Pune. So all of you must have received the messages and links for registration. Do join us at Pune NAPCON. Avya, the stage is yours.
Thank you so much, madam, for that wonderful introduction. Now, I have set up a few questions for our esteemed panelists, and I would like to make it even more interesting for the benefit of the audience. So, we'll be starting with you, Radha, madam. So, my first
Yes.
question to you is what is the incidence of fungal infections in the ICU which you encounter in your day to day practice?
Um, Basically, Avya, I would go back to what Dr. Rajesh Chawla has already quoted, and the fungal infections in ICU, and those who have already are in immunocompromised state, either because they are on steroids, have received a lot of antibiotics, are a solid organ transplant, or even cases who have hemopoietic malignancies. They are more susceptible, and the infection rate ranges, as the literature says, from 40 to it may increase to more than that. And however, in my ICU, we don't come across much, probably because we have set up an ICU quite recently. It's not even more than 10 years old. One. Secondly, the type of patients that we get do not belong to these high risk categories, except that we have had a girl who was on immunosuppressants for autoimmune disease. She was a very young girl, 19 years, and she really had invasive candidial infection. So in our setup, we get it, very few cases are there. There may be more cases in surgical ICUs, post-op, and who are on antibiotics for a more longer time. But in my setup, I get it quite less. But I'm sure with each knowledge that we gain and we have our eyes open, perhaps next time I would be reporting more, because awareness brings us to work more on that particular aspect of disease.
So, very well said, madam. Now, while I had this daunting task of moderating this topic on fungal infections in the ICU, I was also going through a lot of literature, and it astounded me that there were more than 7 million deaths in 2024 because of invasive fungal infections. Now, that's an astonishing amount. And
Yes.
once an invasive fungal infection was diagnosed, the mortality was more than 50%, which was documented. Which is why this topic today, which we are discussing, becomes so very important, that early diagnosis and management can save life and has cost us already 70 lakh lives in the previous year. Now,
That
over
was
to
what
you.
I said, Avya, that being aware about this and more vigilant about it. I'm
Yes.
sure Dr. Chawla won't object to what I say, but we need to be more vigilant in catching these cases early, diagnosing, and then treating the appropriate ones.
Absolutely. So over to you, Dr. Preeti Sharma. Now, what are the common risk factors for patients developing fungal infections, invasive fungal infections in the ICU setup? What is something which you commonly see in your practice?
Yeah, first of all, good evening to all of you, and thanks to Indian Chess Society and Amita ma'am for being here, giving me the opportunity to be on this platform. So, as discussing already, we have a number of risk factors which we need to keep in mind, and we need to suspect these infections. Like we have prolonged ICU stay patients, patients who have severe critical illness, Apache scores more than 20. They have prolonged stay on the mechanical ventilators. They have all these devices set in, the central venous catheters, the other urinary catheters, as well as hemodialysis catheters. Patients of malignancy who are on chemotherapies also, very different set of patients who are on immunosuppressive therapies, the post transplant patients who are either bone marrow stem cell transplant patients or solid organ transplant patients who are receiving long immunosuppressive therapies, patients who are receiving kind of TNF alpha inhibitor therapies also, or tyrosine kinase inhibitor therapies are also at risk. Then there are patients, as sir also discussed in his PPT, the chronic health condition of the patients, like even the diabetes patients, the CKD patients who are on long-term hemodialysis, as well as the chronic liver disease patients and the chronic lung condition patients. So these set of patients who, and in ICU, we give a lot of broad spectrum antimicrobial therapies, the patients who are on long duration of antimicrobial therapies, all these set of patients will be as a risk factor who will develop the fungal infections, and we need to have a close eye on these set of patients so that we pick up early. As you discussed, that mortality rates are very high if we don't pick up these infections.
Very well said. Also, something which I've seen very commonly in our ICU is in cirrhotic patients and patients with pancreatitis, the incidence of fungal infections is definitely higher than the normal subset population, apart from all the risk factors which you said. Once HIV has been on the decline, our threshold for diagnosing fungal infections became at the ease until and unless we've seen a pandemic, which has again started to come up. Now, coming over to the types of organisms and the common pathogens which are seen in these fungal infections, I'd like Dr. Komal Shah to shed some light on this topic, please.
Good evening, everyone. And first of all, thank you so much, ICS and Dr. Amitanini Madam, for giving me this opportunity. And I also take the pride of welcoming you all for the NAPCON 2025 at Pune on behalf of the entire team Maharashtra. So please join us from 23rd to 26th of Jan for NAPCON Pune. Now, coming back to the question, if I have to classify the fungus, it will be like yeast, mold, and the dimorphic fungi, plus PCP and Cryptococcus. So, yeah, when we start with the yeast, it is Candida, which is the most common, as we have already discussed. The most common invasive fungal infection in ICU would be Candida, and which can be divided into subspeciation like albicans, which was very common previously till 1980 to 2000. But now we have non-albicans, which are taking over, and they are like in India, the most common one is Tropicalis. Then there is Candida glabrata, which is common in United States, and it is mostly seen in geriatric patients. Plus, there is, and it is resistant to fluconazole. Then there is Cruzi. It is again resistant to fluconazole. One very important point, sir, already mentioned in his talk, is about Candida auris, which is MDR, multi-drug resistant Candida, and it can be resistant even to the echinocandins. So these are the subspeciations of Candida. Then we come to the molds, which will be like Aspergillus and Mucor. Then in Aspergillus, it will be Aspergillus fumigatus, which is the most common. Aspergillus flavus, which is more involved with sinusitis, and Aspergillus niger, which is like causing the important cause for aspergilloma, and Teres. And these species are again multi-drug resistant. In mucor, we have Rhizosporus, Rhizomucor, and mucor species. Then we go to next, that is Cryptococcus, PCP, and then dimorphic fungi, which are mostly endemic fungi like Histoplasma, Blastomycosis, Coccidioidomycosis, etc., etc. So this is how we can divide. But out of this, Candidas are doing like almost 80% prevalence, and then 20% is Aspergillus and Mucor.
Thanks, Dr. Komal, for beautifully summing up the classification of pathogens. Now, Dr. Antony, we've been speaking about fungal infections in the ICU. Now, what do we exactly mean by a fungal infection in the ICU? How do we define what a fungal infection typically is?
Okay, good evening, everyone. I'm Dr. Antony, and thanks for giving me such an opportunity. Thanks to Amita Nene Madam and Indian Chess Society. So, I'll be actually starting with the definition by the European Organization of Research and Treatment of the Cancer. Okay, and we would have heard about this definition like EORTC, MCGERC. So for this, for some people who won't be having any idea about what this is, it is none other than European Organization for Research and Treatment of Cancer and Mycosis Study Group Education and Research Consortium. Actually, this was dated back to 2002. It started at that time. Actually, while we discuss about the fungal infections, all the people would be, or the subset of population always would be the people who receive the transplant, solid transplant organs, the people who are suffering from cancer, or the people who are who get the transplant, stem cell transplant, hematopoietic stem cells transplantation. So there is a problem because this is not covering the complete ICU patients. So in order to circumvent or in order to this condition, in 2003, a meeting was done worldwide, and according to it, the EORTC, the European Organization of Research, has given few words. I mean, few definitions. For example, proven, possible, and probable. Actually, for invasive fungal diseases, these definitions were updated in 2008. Since this was not covering the ICU patients or the pediatrics patients, it was only covering the cancer patients, recipient of hematopoietic stem cell and solid transplant. Also, the certain shortcomings of earlier definitions where they were not covering, as I told, and there was uncertainty about the beta D glucan test, and also there were uncertainty about the polymerase chain reaction because it was also not included in this. So the main objective of EORTC MSDRC was to overcome this difficulty and provide the definition for the most common invasive fungal infections in our ICU, that is invasive candidiasis and invasive aspergillosis. So two words I have told, proven and probable. So what do you mean by this proven? Proven means if the fungus is detected in the blood culture or it is proven by the histopathology from a biopsy or microscopy taken from a normal sterile part from our body. It should be a sterile, not the contaminated one, in both immunocompetent as well as an immunocompromised patient. So that is an inclusive definition. Sometimes and on the other side, the probable one, it depends upon the host factors, the clinical feature consistent with the disease, and also the mycological evidence that may include the beta D glucan or the PCR or the microscopy. To just going into detail, if you are talking about invasive candidiasis, there are three actually. So sometimes in the blood it is candidemia without a deep-seated candidiasis, or candidemia with a deep-seated candidiasis, or deep-seated candidiasis that which is not associated with candidemia. Okay, so in this case, the proven candidiasis will be the isolation of candida species from the blood culture. As Sir was telling, 20 to 30 ml blood culture is definitely needed, and two pairs of blood culture should be there, and one is from anaerobic and one is from two from aerobic and two from anaerobic. Then histopathological and cytopathological evidence, probably it can be from an aspiration or from a biopsy from a biopsy specimen. So that is a proven invasive candidiasis in the ICU. Also, if you are getting the candida from the sterile out of a sterile procedure, that is from a surgery, or if you are getting a candida from a drain which is placed within 24 hours, not after that. Sometimes the skin commensals will come into the drain, and also the blood culture. So this is the proven IC. So it has to be seen from the biopsy or from the blood culture. But in probable, at least one of the clinical criteria. The clinical criteria of invasive candidiasis in probable that includes the ophthalmological findings or some findings you get in hepatosplenomegaly, that is candidiasis that affects bullseye lesions in the hepatosplenomegaly, or radiological evidences. Then at least you need one mycological evidence, for example, increase in one beta D glucan, or in two consecutive specimens, or some abdominal specimens also, which you get out of it. Then and after that, you must have one of the host factors. If the patient is on glucocorticoid therapy, that is more than 20 milligram one day, or the neutrophil count is less than 500, impaired gut integrity, then impaired gut barrier, like the patient is using central lines or HD catheter, then of course the solid organ transplant. The same thing is definitely applied for the invasive aspergillosis also. The proven category means the same thing. You are seeing this filamentous things in the biopsy, and also the at least one of the clinical features, one of the mycological features. So in case of aspergillus, the difference in the host, the features, the host features would be air crescent sign in radiological, then cavity in the lung you see in the radiology, then well circumscribed lesion without a halo sign, or with or without a halo sign, wedge shaped segmented lobar consolidation, and tracheobronchial ulceration. Also, the other risk factors, which includes decompensated CLD, steroid use, and neutropenia. So, in short, the EORTC and MST defines this fungal infections to be in the ICU as proven and probable, so that even if you don't get the fungus in a biopsy specimen, because it is very difficult in ICU, because a patient in respiratory distress, a patient with the coagulopathy, you can't get this biopsy specimen. It's very difficult. So in that case, you can depend upon the probable diagnosis and you get treat the patient.
Thank you, Dr. Antony, for that elaborate explanation on definition of fungal infections. Now, coming to a more common scenario which we see, Chawla sir, we often see candida infections across the ICU, right from topical to colonization to commensals. Now, what is the spectrum of candida, since it's the most commonly encountered pathogen in the ICU? What are the different presentations which you commonly see, sir?
See, the different presentation, of course, one of them is, as I said, let me first talk about the species. You see, as I said, tropical is number one, Candida auris, and then patients with catheter paracellosis. Depending on the ICU to ICU, see glabrata, some cases of cruzi, and these are still the common Candida species. Commonest is a patient who's been admitted in the ICU, has received multiple antibiotic for 7 to 8 days. He's got better. He's diabetic. He probably is on dialysis and now raises a fever. You should start thinking of fungal infections. He may have another risk factor. This is the commonest presentation. And what we do is, in these patients, we see if there is any other source of infection. That's number one. Still, the bacterial infections are more common than the fungal infection. Then if you have ruled out there is no possibility, of course, you send cultures for everything. If you ruled out the possibility is not there, and it is 7-8 days have passed in the ICU, so you start thinking of heading empirically. You send blood culture in these individuals. Wherever possible, if there is any sign in that patient, sterile sample can be obtained, you send it. Because, you should always remember, sputum and urine, these are the two will very commonly in the ICU will grow candida. They are colonizer. In the urine also, if that you have a source of infection which you can really explain, you should discard it. You should not treat if you find the candida in the urine, because many a times it is treated, and only under a few circumstances, like you've done any urological procedure in a child, in a pregnant lady, then only you treat these. Or you feel this is definitely the infections and there is no other source and you are finding there only, and there is another sign, then you can treat candida in the urine. Otherwise, just don't treat candida in the urine. Similarly, in the sputum, because these are the two, why I am saying again and again, unnecessarily antifungals are given. Look for another source of infection. Patient may have another source of infection. So the second presentation is an immunocompromised host. They come with high grade fever, and they have been carrying these risk factors for a long time. Right from the beginning, you start thinking that this could be associated with fungal infection. Third is the neutropenic patients. You give them antibiotics, they do not respond. You think probably there could be fungal infections. So these are the common, and the transplant patients, you think of all fungal infections in them. There is a possibility of aspergillus, there is a possibility of candida. Even based on the presentation, we think of mucor. These are the patient where bronchoscopy and all these things do help to diagnose the fungal infection. So these are the 4-5 presentation, but the most common is patient presenting with the primary illness. He's received antibiotics and has other risk factors, raises fever or other sign along with it. You think of candidemia or fungal infection.
Thank you, sir. That was extremely helpful and crisp. Dr. Munje, madam, before we go on to the treatment of fungal infections and diagnosis and management, I have a very important and burning question which Dr. Chawla has been clearly emphasizing on: when not to treat. So, when should one
Yes.
not treat candida? What is the threshold for actually saying that no, this is just a colonizer, I am not going to treat it?
I'm not aware about the threshold values, Avya. I think
Not,
Dr.
yeah.
Rajesh will be the best person to talk about it. But Anthony's and Dr. Rajesh's answer has been very self-explanatory, and they have already defined what is to be treated and what is not to be treated. So, if you isolate Candida from the sputum in a unsuspected case, or a case who has been symptomatic but there has been no fever, there is no clinical deterioration, or there is no leukocytosis, then these are the cases where you should not be treating for Candida. When we talk about BAL or bronchoscopic samples, I would always go by what we really do day to day and see. If you are going through either the nasal cavity or per oral, and if you see that there is a candida lining which you can easily see with your eyes also, then at that time, if it is possible, positive, probably what has happened is you have just taken those samples or it has contaminated your bronchoscope. And clinically, of course, the patient does not have any other indication which has been discussed, like a patient is neutropenic, or patient who has been admitted, received antibiotics, responded, and had another spike of fever. If all these things are absent, then I think you should not be treating this candida which has come positive in sputum or even bile or even in urine. But about blood cultures, whenever the blood culture is positive for candida, and whenever there is the doubts that a patient has had fever, because that is why you have sent a blood culture. A patient in ICU who has so many lines, he has central line, he has a catheter there, then parenteral nutrition is going on. Perhaps even the patient may be post-surgical apart from other high risk which they have already defined. In such case, if the blood cultures are positive, I think this is the time when you should really start treating rather than waiting, because the literature says that even if you delay by 24 hours, the mortality is going to be high in such cases.
I think very well said, madam. I'd just like to summarize that whenever we are dealing with a candida in the ICU, we must understand four basic principles: whether it is a prophylaxis treatment, whether it's a preemptive treatment, that is a high risk individual, whether there is empirical treatment when there is fever, or whether there is targeted treatment when there is a culture positive.
Yes. And
Prophylactic,
culture positive, as I should have added, that colony forming units must be more than 10 raised to 6 per ml. So
correct.
if that is so, then it definitely warrants treatment.
Yes. So for a prophylaxis and preemptive situation for candida, we should not be treating. An empirical situation which is fever driven, when all possible causes of infection are ruled out, then empirical treatment can be started. And obviously, culture driven practice, that is targeted therapy, has to be considered for all candida. infections. Now, moving over to Dr. Preeti Sharma, madam. Now, what is the diagnostic criteria for invasive fungal infections in an ICU setup? Now, how do we diagnose an invasive fungal infection? Because a tracheobronchial infection versus an invasive infection will have a different duration of treatment. So, can you share some light on this, madam?
So while diagnosis, we need to have one or more of the following where we have already discussed also. We need to have, first of all, a positive blood culture. That would be the either of the criteria, or you have a positive culture from a specimen which is obtained by a sterile technique from a normally sterile site. Along with that, you have some clinical radiological picture of an infectious process. Then, thirdly, you need to have kind of a histopathology or a cytopathology or even a direct microscopic evidence from a specimen, which has to be further confirmed by a culture or a PCR technique. Or fourthly, if you have a positive PCR, which has to be followed by a DNA sequencing. So these will apply to both the molds or the yeast, whatever we get in the cultures. And if we get any of these, we prove that there is an invasive fungal infection, whether it is a candidiasis or it is an aspergillosis. But in the other cases, where we are trying to give an empiric treatment, where we apply some of our risk prediction models, as Sir discussed in the PPT, therein we can go along with the serological tests like 1,3-beta D-glucone, where if the levels are more than 80 pg per ml on 2 instances, then we have a very good we get the reports very easily before the culture would come positive. So in those cases wherein we have a high risk prediction model plus serological test positive, we can always go for our empiric therapy till we obtain our cultures. So therein we go as for the probable, or we say that whether we have not still suspected invasive fungal infections. So, and for aspergillosis, we need to have a serum galactomannan or a bile galactomannan specifically sampling, which we can get the results better and very early rather than till the time we get the culture and we start the final therapy. So without wasting any time, we can always start our therapy until we get the final culture reports.
Thank you so much, Dr. Sharma, for an excellent elaboration. I'd like to add one point that whenever you're drawing a sample from an indwelling catheter, the sample should be taken within 24 hours and not later than 24 hours. If you've taken a sample from a catheter more than 24 hours, then most often it would be a contaminated or a colonized sample. Now, continuing with what Dr. Sharma has shed light on the serology, Dr. Komal Shah, can you tell us about the serological importance and the role of serology and its markers in diagnosing fungal infections in the ICU?
Yeah, sure. Thank you for the question. So I'd like to go with two most important markers, that is 1,3-beta-D-glucan and galactomannan. So 1,3-beta-D-glucan is basically a fungal cell wall component, and it is the assay is increased in.
I think we lost Dr. Komal Shah due to poor network. Yeah, she's joined back.
Komal, you can switch off your video and talk. That would help.
Hello, can you hear me?
Yes.
Think beta-glucan. Beta-glucan is fungal wall substance, and the assays are increased in particularly in Candida, in Aspergillus, and in BCG. And it comes negative in Mucor and in Cryptococcus. The sensitivity is around 70 in invasive candidiasis. The sensitivity is around 70 to 80%, and the specificity is around 75 to 80%. However, there are false positive findings in cases like hemodialysis, albumin, when we are giving immunoglobulin use or concurrent use of any other antibiotics. Now we talk about the galactomannan, which
I think we've lost her again. We'll just wait for a moment for her to rejoin. Hi, Komal, are you back? Okay, can we have... Yeah. Komal, can you hear me?
Yeah, I can hear you, sir.
Yeah, please start from galactomannan. That's where we lost you.
Okay. So galactomannan is the polysaccharide component of the cell wall, and it is detected by the value is measured by optical density, and it is different in serum and bile. For serum, it is more than 1, And for BAL, we have two values, that is more than 0.5 or more than.
I think we're having some connectivity issues with Dr. Komal. We'll move on to the next question till we have her back. And in the meantime, admin can help her with her connectivity. Oh, yeah, she's back.
Now I'm now I don't know where we like. Should I start with
Serum,
the galactomannan again?
serum galactomannan levels, and you were on BAL galactomannan of 0.5 and
Yeah,
1.
yeah, yeah. So Bal galactomannan, we have two cutoff values as per different papers. They are mentioning that zero point 0.5 is also can be considered positive. However, the sensitivity with zero point 0.5 is around 88% and sensitive specificity is around 80%. But when we take the cutoff value of 1 in Bal galactomannan, the sensitivity, however, is a little less, that is 78%, but the specificity increases by 93%. So more than 1 has a more sensitivity when it comes to Bal galactomannan. When galactomannan is combined with PCR, it has even higher sensitivity. However, the galactomannan levels are falsely positive in patients. Previously, it was mentioned that when the patient is receiving piperacillin tazobactam, even after stopping the antibiotic for around 5 days, it can still come positive because piptas already has galactomannan in the component. But now these new formulations of piptas do not have galactomannan, so now it is said that even with piptas, it cannot come falsely positive. However, it has cross-reacting antigens with histoplasma frusium, other penicillins. Even first 100 days of chemotherapy can give rise to false positive levels of galactomannan. So these are some important points we need to remember. Even Bal galactomannan, in some papers, they have mentioned that we can use as a serial marker to look at the response of antifungals or to look at the as the marker whether it is decreasing or not after using antifungals.
Thank you, Dr. Komal. I think we've all, it's safe to say that all of us have kept a threshold of 1 for a bronchoscopic lavage sample of galactomannan. And yes, there is a proven interaction with the piperacillin tazobactam. There are some literature and studies which also say that the use of meropenem can have a falsely positive galactomannan. It has to be taken with a pinch of salt because the same paper talks about amoxiclav as well. So in the right clinical context, the threshold value has to be correlated. And yes, a galactomannan positive in the empirical fever-driven pathology would warrant treatment with an appropriate antifungal. Now, moving from serology to molecular-based testing, as COVID-19 has taught us the over-reliance on PCR-based and the judicious use of PCR-based technology, Dr. Antony, can you tell us the importance of PCR-based tests in the diagnosis of fungal infections?
Sure, sir. As we know, PCR, polymerase chain reaction, as everyone knows, it is rapidly. This test is often, rapidly detecting test. So, in case of fungal infections, it takes a lot of days for the culture reports to come. So, in some cases, people wait a long time so that to treat the fungus, which may cause the mortality more. So to avoid this condition, PCR has been we have been widely using these techniques. So to tell it precisely, we take the sample. This is our amplification of a genetic part. For example, certain regions like 16S rRNA, 18S rRNA, then internal transcribed spacer, then you can amplify the DNA. So this is how you can take the specific genome, or specific nucleic acid from a species, and then you amplify it. Then you find out which the species is. The commonly which the specimens which being taken as blood, then ball, then tissue. Rarely we take ET miniball from intubated. Okay, we can take that also. So the main thing is that while you do the PCR techniques from 80 minutes to 2 hours ranging, you can get the diagnosis out of it. And while you use ball and blood, the sensitivity will be around from 43 to 99 percentage, because it is a wide range of sensitivity in case of blood, that is 43 to 100, and in case of ball it is around 64 to 100. But there are some limitations with the PCR technique. That is, if you are the fungal wall is so thick that it will be very difficult to break the cell wall and get the DNA. So sometimes in that case it will be false negative, or on the other hand, if you get contaminants if from the specimen, so it falls positively, it also PCR also will be positive. So in short, PCR, okay, along with the microscopy, or if you want to get 99% of sensitivity, polymerase chain reaction along with the beta D glucon, especially in case of candidiasis, beta D glucon, and if you get both the values increased, so that in that case the sensitivity can be around can be found out as 99% of that. You can't say that theoretically it's been you can't say BAL, because in case of BAL you will have a lot of commensals. So if you take through the bronchoscopy, if there are commensals, that also would be, sometimes the patient would be devoid of symptoms, but it will, the PCR shows BAL as to be positive. In case of candidiasis, I think blood is more useful. For example, if you are taking more volume of serum, in some studies it's been shown that the pellet fraction of BAL, not the supernatant fraction of BAL, the pellet fraction of the centrifugal BAL will be more sensitive to find PCR. So to conclude, PCR along with the other findings, or PCR along with a beta D glucon in case of candidiasis, can yield result very fast, so that you can treat the patient at the earliest.
Thank you so much. Also, a lot of mucor PCR testing has been done ever since the COVID pandemic and the kappa scores have increased. But I would be the devil's advocate about the sensitivity of blood and BAL-based fungal PCRs, that often it's an expensive test and the yield becomes poor. And therefore, being in close contact with your microbiologist often gives you a better idea whether it's a septate or an aseptate hyphae, which gives you direction in which antifungal to proceed. But yes, more validation is definitely required. Now, moving to septate and aseptate, let's talk to Dr. Rajesh Chawla, sir, for the importance of bronchoscopy in diagnosing invasive fungal infections, and when to scope and when not to scope a patient in this situation. Should we rely on a mini ball from the endotracheal tube, or actually put a bronchoscope and take a lower respiratory tract sample?
No, it all depends what are you looking for. You see, for Candida, you don't require to do a bronchoscopy because you can get it just like that. But if you are thinking of aspergillus, then bronchoscopy from the area of involvement, not only you obtain sample, you also obtain sample for galactomannan, which is considered to be much more sensitive and specific. If I'm thinking of mucor in an immunocompromised patient, the bronchoscopy has much more use than in an immunocompetent patient, because you can get not only the aspergillus, if there is a possibility of mucor, if there is a possibility of pneumocystis cerevisiae, which is also a fungus we don't talk about, it's more common in the immunocompromised patient. So if there is an immunocompromised patient, like a transplant patient, we always do bronchoscopy because the sputum is not there. There is no other way to diagnose, and you should quickly do, because these patients are immunocompromised based on the immune status, how much immunosuppressive they are being given. Many a times you will get a PJ also, you will get aspergillus also, AFB also. So, it is very, very important to do bronchoscopy in an immunocompromised patient if there is a possibility, not only fungus, for diagnosing the undiagnosed pulmonary infection. But just for Candida, you need not do a bronchoscopy. I mean, it is, as I said, even isolation is not going to help you. So you are not, even if you isolate, it is not going to help you unless there are other reasons, there are risk factors, there is pneumonia. But if there is a pleural effusion and you are thinking of Candida pneumonia, the pleural tap would be much more useful because that's a sterile site. And if you isolate, which hardly I remember cases where I isolated, that would be more useful rather than just sending a ball for Candida infection.
Very well said, sir. Thank you so much. Now, moving over to Radha, madam. Madam, like Dr. Chawla has already mentioned in his presentation, can you reiterate the classification of antifungals before we move on to the treatment? A masterclass once again.
Yes, but before I take that, I hope Dr. Chawla allows me to add that apart from that, Even diarrheas in ICU, we should start suspecting whether there are fungal infections. Apart from one which occurs because of overuse of antibiotics. Then, yes, I move on to the question which has been given to me. And Dr. Chawla has shown a wonderful slide which showed us that there are drugs which are pollens which act on the cell membranes. And these drugs are amphotericin B and, of course, lipid combinations of amphotericin B formulations and nystatin. Then those who act on cell wall are echinocandins. These are capsofungin, micafungin, and andidulafungins. And azoles, which are the commonestly and most widely used antifungals, are the drugs which acts on cytoplasm, and these are fluconazole, ketoconazole, itraconazole, voriconazole, and posaconazoles. And now even some DNA antimetabolites are also being used as antifungals. So these are the different types of antifungal drugs that we have.
Thank you,
And
madam.
the drugs which I mentioned of these ketoconazole and clotrimazole are commonly used for topical infections, whereas for fluconazole and itraconazole and posaconazole we use for treating the infections. Or I mean systemic infections
Systemic infections.
or invasive infections.
Thank you, madam. Now let's go on to the treatment of these invasive and fungal infections. So, Dr. Preeti Sharma, madam, can you talk about the drug of choice for Candida or the first line therapy for Candida infections in the ICU setup, and how do we monitor? What would be the dose?
Yeah, the first line therapy for, if we talk about first invasive candidiasis, we have echinocandins as the first line treatment for invasive candidiasis in the patients who are critically ill. They are in the septic shock with multi-organ dysfunction. So these echinocandins, they have a good safety profile. They do not need any renal modification. Just for caspo and micafungin, we need modification in the liver failure, which is moderate to severe renal failure we need. And for enidulafungin, we do not even need a liver dose adjustment. So these are caspofungin, micafungin, anidulafungin, and rezafungin, which is the latest new drug. Caspofungin is given in a dose of 70 milligram, which has to be given as a loading dose, followed by 50 mg per day, once day. And then micafungin has to be given as 100 mg per day. Enidulafungin has to be given as 200 mg of loading dose followed by 100 mg per day. And rezafungin has to be given as a loading dose of 400 mg followed by 200 mg, which has to be given weekly. So all these drugs, they have good penetration at most of the sites, except if we talk about the CNS, eye, as well as urine, wherein these echinocandins do not act. So if we talk about the first line therapy in a stable patient or a milder form of the disease, wherein our fluconazole stands there, but we have to take into consideration whether it is a Candida albicans or a non-albicans Candida. In non-albicans Candida, if we talk about the species of glabrata and cruzi, which are actually inherently resistant to fluconazole, so therein we don't use fluconazole. These species have good susceptibility towards echinocandins. One more point, echinocandins have low susceptibility towards Candida parapsilosis and Candida auris, as sir also described in his PPT, wherein we may have to increase the doses or we need to have a check-in whether the patients will respond or not. So for rest of the species, echinocandins work very well. For the fluconazole resistance patterns, that has to be taken care of if we have Candida glabrata and cruzi, wherein fluconazole will not work, wherein voriconazole has shown promises, but that is again a second line of treatment. We are just talking here about the first line treatment. And if we talk about the mucocutaneous or esophageal candidiasis, wherein fluconazole remains the drug of choice, and we give it in a dose of 150 to 200 mg if it is a mucocutaneous. For esophageal candidiasis, we give it as a dose of 200 mg per daily. The side effects seen with these profiles are not much, but some of the infusion-related side effects are seen with echinocandins. That's kind of an Redmond syndrome also, as seen with vancomycin, but they're very less than 10% of the cases we see these side effects. On the GI side effects, as nausea, vomiting, diarrhea, and these kind of side effects, again seen in very less number of patients, in less than 10% of the patients.
Thank you, madam, for elaborating on the use of echinocandins in the ICU. I'm going to take a step back and go to Dr. Komal Shah and ask her about the importance of starting loading dose of fluconazole when we are suspecting candidemia in our patients. And fluconazole remains the most easily and affordable drug which is there. So, can you share some light on this therapy, followed by a non-responsive patient to an
Yeah.
echinocandin?
Yeah, so most if there is Candida albicans, it is still sensitive to fluconazole, and I am glad that you asked this question because fluconazole has been given in a very wrong dose. Whenever you are seeing the most of the prescriptions, they are writing 200 BD or something like that, and there's no loading dose. So we should always remember it is 800 milligram loading dose followed by 400 milligram OD. It is 12 milligram per kilogram is the loading dose, and 6 milligram per kilogram as the maintenance dose. Also, we should, as Sir mentioned earlier, the duration of therapy should also be considered. It is 2 weeks after the cultures are negative. So that is 14 days after culture negativity. Plus, if it is something like endocarditis or any other disseminated infection, then it is around 6 weeks. So these things should be kept in mind. Wherever there is resistant to fluconazole, in case of non-albican species, then we can go ahead with the echinocandins. And in cases like auris, then we have to also look for amphob or some other option. Also, there are some articles which are mentioning about the combination therapy. However, there are 3 guidelines. The recent guidelines are ESIC guidelines, the IDSA guidelines is 2019, and there is Austria Asia guidelines, this is 2021. None of them mention about the combination of therapy in invasive candidiasis. But in some of the articles, in some literature, they've used echinocandins with amphotericin B or echinocandins with azoles in cases where the patient is critically ill, in septic shock, and immunocompromised. In that case, they have used, however, there are no such guidelines for mentioning the same.
Very well said, Dr. Preeti and Dr. Komal. Understand whether it is an albicans and non-albicans before deciding your drug of choice, and then accordingly use fluconazole at the right appropriate dose of 800 followed by 400 versus a Caspo, Mica, or an Anidula fungin. And in resistant cases, amphotericin B can be considered as a life-saving measure. Now, moving to Dr. Antony. Dr. Antony, what is the drug of choice for aspergillosis, and how do we treat aspergillosis as first-line therapy?
Actually, speaking about aspergillosis, the most common species which affect the people in ICU is Aspergillus fumigatus, and the most common manifestation is the pulmonary one, invasive pulmonary aspergillosis. According to the IDSA guidelines in 2016, voriconazole is the first drug of choice to treat the invasive aspergillosis, or you can also use isavuconazole in view of toxicities that pertain to voriconazole. In case of severe neutropenia, or if the patient is having severe clinical issues, then you can go for a combination therapy along with the echinocandins. So first we'll talk about the dose, because while you in the ICU, dose is definitely important, because you shouldn't we can't afford to have an underdosing or overdosing of such antibiotics. In case of voriconazole, we can give IV or oral. Both, it is 6 milligram per kilogram IV, 12 hours on day 1. And after that, 4 milligram per kg IV every 12 hours after that day 1. Then you can change to oral. That is, if the clinical features pertaining to it are getting reduced, you can make to 200 BD. But if the disease progression is still there, then 4 mg per kg orally BD can also be used. Since if you feel that it is not coming down, the clinical features are not coming down, then you can give up to 300 milligram BD. That is 4 mg per kg. Then so this is about the treatment of voriconazole. Then certain things can happen while you treat the patient, because certain species of aspergillus can have inherent resistance to certain drugs. For example, in case of aspergillus fumigatus, certain studies say that in United States 99% they are susceptible to amphotericin B as well as azoles. But certain cryptic species of aspergillus, like Aspergillus lenticulus or Aspergillus calidostus, they are inherently resistant to voriconazole and amphotericin B. In that case, it will be a very tough time in treating those kind of species. Then next, after if the patient is having the side effects of voriconazole, for example, the problem with voriconazole will be visual hallucination, neurological symptoms. In that case, you can, if the toxic doses are there, isavuconazole or posaconazole can be preferred. If there is a chance for QTC prolongation in case of voriconazole, in that case also isavuconazole can be preferred, or liposomal amphotericin B can be also used in voriconazole resistance. So I'll be right now telling about the dose of voriconazole. I just told about the dose of voriconazole. I'll be talking about the dose of posaconazole and isavuconazole. Okay. I think mainly we are, so I think just for an academic, this only I just explained about ISAU, because 372 loading dose, it's a prodrug, and posaconazole we can give 300 mg BD on day 1. So more about voriconazole. So
Thank you
that's
so much, Dr. Antony. So, yes, the drug of choice remains voriconazole upfront for the treatment of aspergillosis, unless there is a cryptic mutation in the Niger and fumigatus genes, which we see with CYP51, which is commonly associated with resistant cases, where we consider second-line therapy. So, Chawla sir, when do we consider alternate azoles or amphotericin B in the treatment of invasive aspergillosis, and is combination therapy advisable in such cases?
First of all, I think it is important to know the bioavailability of oral tablet in these drugs, voriconazole, posaconazole, and isavuconazole, is very good. So the other thing is they need to be given with food, because this enhances the absorption of these. These are the two very important things. Voriconazole, of course, is the drug of choice. The IV is nephrotoxic because it is made with cyclodextrin. So if it is a patient of renal failure, probably you should go for a oral, or where there is a possibility that renal function are deranged, you should go for oral. Most of the time you would find the oral working. If it is not working, then probably you can go for the posaconazole. The drug interactions are also quite high with the voriconazole. You could go for the isavuconazole and posaconazole. Both these drugs are expensive. The posaconazole is given 300 milligram on the first day, twice a day, and then once a day. Similarly, isavuconazole, you give 200 milligram TDS for first 2 days, and then you go on to the OD dose. And as far as the combination is concerned, if patient is there, although there is not much evidence, there are 3-4 studies where they have tried amphotericin B along with voriconazole. There is a echinocandin tried with voriconazole, and even both the azole, voriconazole along with posaconazole, they have been tried. And what they have found, there is increased outcome, good outcome, and better survival. These are not very large studies, but most of the time you should go for voriconazole. Not working, you could go for the liposomal amphotericin B, or you could choose one of these. And if patient is extremely sick, not responding, proven infection, then you can go for one of these combinations.
Well said, sir. That a combination therapy can achieve success. Now, I'd also like to add another point when Dr. Preeti was telling about echinocandins. Now, when we have a life-threatening situation with invasive candidemia, we can increase the dose of echinocandins by 50 to 70% and continue the loading dose itself for whatever it's worth. And it has shown to achieve some success in reversing mortality. So the loading dose and a maintenance dose, but in severe cases, a loading dose can be continued as the maintenance dose in invasive candidiasis when it is life-threatening. So moving on to the next fungus, which was the black fungus, like in the COVID days, we would call it. Radha, madam, can you tell us about the first-line therapy which we can offer for mucormycosis?
Yes. When you talk about mucormycosis, Avya, I know, and I think everybody will recapitulate what everybody has gone through, the fears of mucor at the time of COVID infections. And perhaps it has also increased our awareness about mucor. And we all know that mucor is a serious fungal infection and it requires a prompt and effective treatment. And first line therapy includes primarily liposomal amphotericin B formulations, and these are the cornerstones for treating mucor. Of course, as Dr. Chawla has said earlier, also for aspergillus, the same drugs can be used, like isavuconazole as well as posaconazole, can be used alone or in combination with amphotericin B to treat the mucormycosis. Um, I have come across a good chart which says that aspergillus active triazoles can be used along with voriconazole or posaconazole. And whenever there is a clinical scenario where mucormycosis is suspected, the first and foremost is you prove by taking the scrapings from wherever it is, except from the eye. Like you can take scrapings from the floor of the nose or from the sinuses, and of course the samples that you have taken through bronchoscopies in the biopsies also. And the first and foremost, before you go on to the treatment, you have to immediately even consult the surgeons and evaluate the risks and benefits for targeted resection or debridement wherever it is needed and indicated, and as early as possible. And of course, you would not give any prophylaxis, but start treatment with liposomal amphotericin B in the dose of 5 milligram per kilogram. And if the infection is severe, you can increase, or if the patient is not responding, the dose escalation must be considered to 8 to 10 milligram per kilogram. And what is important is that these patients have this mucor infection because of all the conditions that we have said time and again, that patient may be diabetic, have been on steroids, on immunosuppressants. So you have to also look into tapering the steroids, withholding the immunosuppressive treatment or monoclonal antibodies if patient is on that, and control of high sugar blood sugar is very, very important when you are giving these drugs. And the combination can be given along with liposomal amphotericin B, and you can add isavuconazole to this, or you can even add posaconazole, and the dose has already been told by Dr. Chawla. It continues to be same, orally 300 milligrams twice a day for day one, and then it can be given 300 milligrams per day for posaconazole.
Thank you, madam. Now we can all talk about sustained release posaconazole tablets, but 4 years back we had the normal tablets which were 200 milligram capsules, and as a result we
Yes,
had to give it 3 times a day. We're fortunate
yes.
enough that a sustained release capsule is available as of today. So, continuing the same thought process to Dr. Preeti Sharma, madam, I've always felt that posaconazole is always a better drug compared to isavuconazole when we are talking per se for mucor because of a penetration. What are your thoughts about it? Do you agree? And how often have you seen and used combination therapy? And do you also agree that surgery and as an add-on therapy in debulking the disease is important in saving a mucor patient because the mortality is more than 50%?
See, as per the studies and even in Europe and United States, isobuconazole has been come up as a first line therapy also for mucormycosis with a very good bioavailability, as sir said, and with the very good safety profile basically, which in the liver renal dysfunctions which we normally face in our ICU patients. Then it has to be given in a dose of 300 mg, which has to be 200 mg, which has to be given 3 times a day initially, and then followed by 200 mg per day, which is available in the IV formulations. And unfortunately, if there is a capsule, we can't break it, so we can't give it through NGs. So in ICUs, we use it as an IV formulations, and otherwise we use it as an oral formulations in some stable patients. Then, if you talk about posaconazole, again, as you told, we had been using initially oral suspensions. Now we have come up with the delayed release tablets, which is given as 300 mg BD initially, and then 300 mg per day is enough for IV as well as for the oral formulations. So, but for mucormycosis, the main important thing is the surgical site has to be taken care of wherever, if it is a debridement needed, which is very, very important as adjunctive therapy to the whatever therapy we are giving, the liposomal M4B for formulations. Along with that, combination therapies have not been much used, but yeah, it is basically a de-escalation. Once we give a liposomal M4B for 2 weeks or 3 weeks treatment, and then we shift over to posaconazole or isobuconazole, and there in these oral preparations will help us that after 3 weeks of treatment with liposomal M4B, we can shift these patients, because this mucormycosis needs a longer duration of treatment, which could go on to the months of therapy. So I think therein it is basically a step down, or the therapy as more helpful as a posaconazole or isobuconazole, where we are using it for mucormycosis.
So I intentionally asked you that question in a catchy way because when we started dealing with mucor right up in 2020, the only drug which was approved by FDA was liposomal amphotericin B. The isavuconazole drug was approved much later as a fast track drug for the treatment of mucormycosis, and very recently only we've got some sort of approval for posaconazole. So, like you very rightly said, the drug of choice remains liposomal amphotericin B. When the patient can't tolerate, consider isavuconazole or a combination therapy. And yes, adjuvant therapy such as debulking the tumor or the tumor of mucor is very important. Now, moving to the safety profile of these drugs. Now, we often see that our ICU patients have some form of liver dysfunction or nephrodysfunction, CKD patients